Um, Hello, everybody, and welcome. My name is Adam Layton. I am an emergency physician and intensivist at Johns Hopkins University in Baltimore, Maryland, in the United States. And I'm really excited about welcoming you all to this first introductory meeting of the Global Critical Care Lecture Series. This is a collaboration between your faculty leaders, Dr. Christian Owoo and Dr. Menbeu Sultan, um, uh, with their institutions in Ghana and Ethiopia that I'll let you guys introduce a bit more, and my university in the United States with support from the WHO as a collaborating center. Um, we are organizing a lecture series that will meet weekly pretty much throughout the academic year to bring together a really phenomenal panel of critical care experts for my institution and other leading institutions around the world to provide some extra academic support uh, for the trainees in Ethiopia and Ghana. We're hoping that this is going to be a useful addition to all of the expert training that you're getting from your local faculty. Um, they'll be speaking on a wide variety of critical care topics that were suggested by your faculty leaders. Um, and really, we have a great number of researchers, educators, and clinicians, many of whom are really national or international leaders in their fields. So I'm hoping this will really be a great opportunity for all of the fellows and faculty who are participating. Um, in addition to that, I will say that I think it'll be a great opportunity for all of those faculty members to learn about the phenomenal work that you guys are doing in Ghana and Ethiopia. I'm sure that they will learn from you guys as well, also. And hopefully, this is also a great opportunity to strengthen the connections between the clinicians and intensivists in your two countries, and an opportunity to build relationships and collaborations between Ethiopia and Ghana. Maybe I'll pause there and let Dr. O and Dr. Munbal introduce themselves and their programs a little bit. Does that sound good, Chris?
Yeah, Adam, that's fine. I think myself, Mambo, Bati, and Amanda are here. I sent an invite to Pa. If Pa was able to join, he could also introduce himself. So my name is Christine Owoo. I am an anesthesiologist intensivist in Korle-Bu Teaching Hospital, Ghana, and a senior lecturer with the University of Ghana Medical School, lead faculty for the Critical Care Fellowship Program of the Ghana College of Physicians and Surgeons that trains physician intensivists in Ghana. Over to you, Mambo.
Thank you, Dr. Chris. Good afternoon, everyone. Good morning for those of you in the eastern part, in the western part, probably. So I am Menbeu Sultan. I'm emergency physician and intensivist working at St. Paul's Hospital Millennium Medical College in Ethiopia. I am leading the department and the fellowship program in critical care. Thank you, everyone. I hope we will have a good time in the coming few months. Thank you.
All right. Amanda, I don't see Bhakti in the list of attendees. Can you go ahead and introduce yourself, please?
Hi, thank you, Chris. Yeah, it doesn't look like Bhakti was able to join us. But hi, everyone. My name is Amanda Bernauskas. I'm a research program manager based in the Center for Global Emergency Care at Johns Hopkins University. So I'm sure many of you have received emails from me already. I've been helping the team to coordinate and get this lecture series put together. So I'm excited to be here with you all and to work with amazing team.
So Amanda, you can also go ahead and tell the rest of us who practice why she's not here.
Sure, yeah. So Dr. Bhakti Hansodi is also an emergency care physician at Johns Hopkins University. And she does both clinical work as well as a lot of global emergency care work and a lot of implementation science research in sub-Saharan Africa. And I'm sure she will be joining us in future sessions as well.
All right. So the other person I had wanted to introduce himself, if he was able to join us, is Dr. Kobina Forsen, who is an emergency physician, and basically with the JPIGO team in Ghana, and he has been instrumental in bringing all of us together during the discussions that eventually culminated in this. If Pa joins us along the line, I'll give him opportunity to basically say a few words on how JPIGO and the USAID has and would continue to support us in this program. So without wasting too much time, Adam, if it's okay, I'll just do a quick presentation of how did we get here, what are our goals, and then what do we expect to achieve. Then we can look at what our scheduling is and who do we already have on board to facilitate this. So I'll share my screen. So I hope you can all see my screen. All right. So we call this program the Global Critical Care Fellows Seminar Series 2024, with expectation that it will continue to run for many more years. And this is basically an innovative idea that basically came about from discussions that has taken that we've had for the past almost 3 years, and eventually it's taken off today. Currently, the partnership is between the team of faculty and fellows of Korle-Bu Teaching Hospital, team of faculty and fellows of the St. Paul's Hospital Millennium Medical College, and then Johns Hopkins Center for Global Emergency Care, where is so the origin is that on the right-hand side of my slide. As I mentioned, I have known a number of these guys who I call my friends for some years now, but the idea crystallized more rapidly during the African Federation for Emergency Medicine Conference that was held in Accra by the Emergency Physicians Group, in which myself and Adam led our team of fellows to present a workshop for participants on acute hypoxia management. And during that, we had discussions which involved Menbeu, who is the vice president of AFSEM, to agree in principle towards a collaborative program that would support our training programs in our two countries. So we know that the burden of critical illness is extremely high globally, and it is worse in sub-Saharan Africa, whilst critical care capacity, including competent human resource availability in Africa, is extremely limited. The need to rapidly develop and integrate critical care into an integrated eco-care in sub-Saharan Africa has been re-emphasized by the World Health Assembly's resolution, AB 1523, that was passed last year, integrated emergency, critical, and operative care for universal health coverage and protection from health emergencies. The important thing about this resolution was that it was spearheaded by African countries, representatives in the WHO, and therefore a lot of impetus by the Director General of WHO and the member nations of the WHO. Ghana and Ethiopia currently have physician fellowship programs in their infancy, but with a huge potential to expand and produce the needed critical care physician providers and trainers for their countries, and eventually to support the growth of the subspecialty in our sub-regions. So, but what are our challenges? As I've mentioned earlier on, we have the heaviest burden of critical illness globally found in sub-Saharan Africa, from infectious disease, non-communicable diseases and injuries, maternal-related conditions and neonatal deaths, neonatal illnesses. Very limited number of physicians and other health workers with specialized training in critical care in our sub-region. And of course, limited training resources for the different methods of teaching. We have limited availability of locally based trainers, and which has necessitated involvement sporadically of colleagues from other geographical areas in supporting the training of our critical care workforce. So what was our initiative? As I mentioned earlier on, the pictures you see here on the top left is actually during the acute hypoxia course at the University of Ghana Medical Center as part of the AFSEM conference, which was a very successful conference hosted by Ghana, the Ghanaian team. We did not just have seasoned a faculty like myself and Adam and Patty presenting to participants, but we did something quite very innovatively. We spent weeks prior to this program getting our fellows to prepare to teach participants, and this were run with the support of our fellows. Afterwards, we were able to take our fellows out to have a good evening at Zen Garden. But while they had fun and then afterwards left, the leads had to go into reflection. And the five of us here, Adam and my extreme left, Pa, Bhakti, myself, and Mambo, had a couple of meetings to discuss how we could collaborate between our two countries, and then with the support of Johns Hopkins into a program that supports our training program. We were agreed in principle. It has taken us a year and a half to arrive at that. And I'm happy to say that every one of us is still part of the team. So what is this initiative? This is an initiative which is being led by two faculty leads from Ghana and Ethiopia, myself, Christian Owoo, University of Ghana Medical School and Korle-Bu Teaching Hospital, and Dr. Menbeu Sultan at St. Paul's Hospital Millennium Medical College in Addis Ababa, Ethiopia. Mambo and I and our faculty colleagues rely on experts from around the world to share their knowledge and insights in various critical care topics and complementary to our training curriculum. To support this effort, the Johns Hopkins University WHO Collaborative Training Center for Eco Care, a part of the Center for Global Emergency Care, were kind enough to come on board and is helping to coordinate a collaborative online lecture series, bringing on board seasoned international and African critical care experts and trainers. And that is the initiative and the support that we have. Our goal is to foster a global exchange of expertise and to enhance the skill and understanding of critical care professionals in resource-limited setting. To complement the current training faculty available to our national fellowship programs, to train the next generation of trainers for expansion of our training capacity, to nurture and integrate our fellows into the and our young faculties into the global community of practice of acute and critical care experts and advocates, to build a network of African critical care experts and expose our fellows and young faculty to active global networks, and eventually to expand this program and initiative to include other countries in sub-Saharan Africa in the near future. So based on this, we sent out invitations and requests to facilitators around the world, in the Americas, Europe, Asia, Africa, and including some of our Ghanaians and Ethiopians in the diaspora. Our invitation to facilitators basically is that we would love to include you in our panel of presenters if you would be willing to share your expertise through online lectures. We are seeking fellow-level topic discussions that address the contemporary standard of care in resource-rich settings that some of you may find yourself in, with potential adaptations for more resource-limited settings that we find ourselves in, and then current research, innovations, and debates in the field. And we've asked that you please respond to our survey when sent to you, indicating your preferences and availability. We look forward to your participation and contribution to this important initiative. And we ask your permission to record and post these presentations on our Open Acute Care website, which is a CGCEC hosted open access website for acute care resources. To our fellows, we request just one thing: your attendance and active participation in the weekly series that we believe would be massively complementary to the training that your local trainers are committed to giving you. So I want to end by acknowledging again the individuals who gave birth to this initiative, and then Amanda for her massive role in coordinating our activities before, now, and going forward. The Ghana and Ethiopian team of faculties and our fellows, Johns Hopkins University Center for Global Emergency Care team, JPIGO, and the WHO. So we really look forward to having you all join us and share your expertise with the fellows, with our fellows, and the larger global critical care community. Thank you. Adam, over to you, please.
Thanks, Chris. Menbeu, did you have anything you wanted to add?
Thank you, Adam. Because there are some presenters here, speakers here, I want to introduce our ICU and the critical care status in Ethiopia. Let me check if I can share my slide.
Great, thanks.
Can you see my slide?
Yep, looks great. Can you hit the slideshow button there? Oh, there you go. Perfect.
And can you hear me?
Clearly, yes. Thank you.
So, hello everyone. Welcome to this session. This is an introductory session, of course, just to introduce our goals and the contents, how it's going to be conducted. For those presenters, I want to introduce the ICUs, our ICU and the critical care status in our setting for in few minutes. So, so you know the definition of critical care. Everyone here knows the definition of critical care, and the incidence of critical care among patients living in among community living in low resource setting is increasing. So critical care status or the patients in low resource setting with critical care condition are increasing, but the number of ICU bed is very limited. So you have to know almost in low resource setting there is the high resource setting have 45-fold increase in critical care beds as compared to in low resource setting, while 80% of the population in the world is living in low resource settings. As you see, this is the availability of bed in different countries. You can see even our country in African countries, all African countries having a good bed number of ICU is South Africa. Otherwise, in Ethiopia, we have only around 0.3 beds per 100,000 population, while you can see in Germany, there is around 30 beds per 1,000 population. So there is low bed availability. Quality of infrastructure will be low. You can see how ICUs are very crowded and unclean, and the corridors also may be unclean. So it doesn't mean all ICUs are like this, but there are also very good ICUs. Overall, ICU is not well developed in Africa, and a large proportion of critical care service are being given outside of ICU, and sometimes non-physicians are giving care for critically sick patients. So we need to change this situation. Epidemiologically, almost 50% of patients being admitted to ICU are having respiratory failure, major head injury, and sepsis and septic shock. So these are the common causes of admission to ICU. Otherwise, pneumonias, hemorrhagic shock, especially postpartum mothers are being admitted to ICU. Overall, young patients are being admitted to ICUs of the low resource settings, and treatable conditions are being admitted to ICUs of low resource setting. But the mortality is too high, almost more than double as compared to the high resource settings. ICU patients being admitted to ICU have high mortality in low resource settings, and septic patients have more than 66% mortality, and among patient respiratory failure, and those patients being admitted from in hospital, or those patients acquiring infection inside the hospital have high mortality. So this is a case like we were managing 30 years old female patient presenting with a series of dysuria fever of 6 days duration, high vitals. You can see tachycardic, some hypotension, tachypnea, and she was desaturating also. So she had also some disorientation and agitation. That means she has some encephalopathy. So she was being kept in emergency with the diagnosis of septic shock, having encephalopathy, respiratory failure, and cardiovascular failure. That means she was in shock also. She was kept in emergency. So because of shortage of beds, these are some of the investigation, like WBC was higher, some thrombocytopenia, and anemia. So the challenge in admitting this patient, there was no bed in the ICU. So we have to manage outside of ICU this kind of patients. So we need to improve the situation. So there is a delay in admission to ICU, and that delay also increase the mortality. Continuity of care also a problem. So we need to consider in our discussions the continuity of care, the ICUs also, the emergencies. The other thing, some of the screening modalities which are being used in the Western setting or well-developed sense are not well approved, or they are not well studied in low-resource settings also. So in airway management, you may get oxygen, but you may not get adequate oxygen for high flow nasal cannula. And intubation also, there is shortage of mechanical ventilator, and the mortality is high in those patients being admitted to. They're being ventilated or intubated in low resource settings. So there is equipment challenge, mainly multiple branded of equipments are being used, sometimes old equipment, biomedical supply for support for repair may be poor, reuse of tubing, unreliable oxygen supply, and other equipment problem you will face in low resource setting. So we have to be familiar with available sedation and paralytic drugs. We may not get ideal drug. Be familiar with direct laryngoscopy. You may not get end-tidal carbon dioxide measurement and other laryngoscopics and antibiotic problem. Sometimes you may have medication problem. Organ support like dialysis may be a shortage. In some study, only 4 ICUs in one country out of 51 hospitals have dialysis capacity. There is a resource shortage. Basic monitoring capacity is low. Invasive monitoring capacity is also low. So, so this is also like you may not have arterial line or other invasive modalities, invasive monitoring modalities. This is just an overview of the situation in Africa, but our goal in this collaboration is to support the fellowships in Ethiopia and Ghana so that we can change the current situation. So these fellows hopefully will change the current status of the poor critical care service in low resource settings in Ethiopia and Ghana especially. So this we have started the fellowship program in critical care in Ethiopia in 2022, and we have 6 fellows. And the first batch of will graduate in this year, September 2024. So hopefully the number will increase. This is the first fellowship program in Ethiopia and the only fellowship program in critical care in Ethiopia. Hopefully it will grow and will be started in other universities also. Our fellows will expand this program and the service. So thank you everyone for supporting this program and to be part of this program. I thank you, and back to you, Adam.
Thanks, Menbeu. And I think you raise a couple of really important points in your comments. One is that critical care is a clinical approach to a patient, it's not defined by a specific diagnosis the patient has. It's not defined by a specific place where the patient is located. And so even though ICU capacity is still very underdeveloped, the clinical practice of critical care, of providing that support for failing organ systems does not necessarily need to happen in a traditional ICU. Also, as you mentioned, with all of the resource limitations that you guys face, it's important to adapt your practices to the resources that you have available. And we know that many of the guidelines that are imported from higher resource countries haven't been well tested in low-income countries. Even there's been some evidence showing that strategies that are effective in high-income countries may be harmful in low-income countries, such as aggressive volume expansion for sepsis. There are interventions that are not effective in high-income countries that may be much more effective in low-income countries, like TXA for postpartum hemorrhage doesn't have a mortality benefit in the US or Europe, but it does in Africa and Asia. And so along with the clinical training that you all are receiving, I hope and expect that you guys will go on to become the clinical research leaders in your country also in establishing the knowledge base to really ensure that we're providing the highest quality of critical care for patients in your settings. I think a couple of other comments about the lecture series. I remember when I was a medical student, one of my professors said, I'm going to tell you everything I know, and half of what I tell you is going to be wrong. And if I could tell you which half it was, I would, but we don't know yet. And I think that you should have that same approach with all of the experts who will lecture to you guys, that what they tell you is going to be the best of what they know, but it may not necessarily be that what they're telling you is going to be feasible or effective in your countries at this time. And as resource availability changes, what is feasible and effective and cost effective will change as healthcare systems continue to develop, and as medical knowledge continues to develop. We will learn that some of the things that we thought were best practices, or that our best practices that we thought were the most effective ways to care for patients may continue to, or will continue to evolve and change over time. And so as much as we hope that you will learn from the lectures that you get, we also hope that you will stay actively engaged in the medical literature, reading journal articles for yourselves, participating in clinical research to stay abreast with the cutting edge of evidence-based best practices as you move forward through your career as both the clinical leaders, the educational leaders, and the research leaders in your countries. Do you guys, should we maybe take a quick look at the schedule for the year? Would that be helpful?
Yeah, so I think we should do that, and then who we already have as facilitators who have come on board to help support us. Yeah.
Great. I can share my screen, Menbeu. I'm going to bump you off and see if I can pull that up. So we have the first half of the year scheduled out already. Like I said, really with a number of wonderful presenters from a number of different leading institutions. We'll have Dr. Kasarabata from Inova Fairfax, that's one of the academic centers around Washington, D.C., talking about fluids in the ICU. Dr. Moses Sawa Frimpong from Ghana, talking about ABG interpretation. Dr. Taraku Asefa from Ethiopia, talking about biomarkers for fungal infection. In about a month, I'll be talking with you guys about post-ICU syndrome. Dr. Tavares from Hopkins talking about non-invasive neuromonitoring. Dr. Grace Imelda Obengaji from Ghana talking about pain assessment and management. Dr. Lorraine Before Awa, also from Ghana, talking about illness scoring systems in the ICU. Dr. Chris Thomas, also from Washington, D.C., talking about right heart failure. Wiltrude Abels from Germany, speaking about sepsis. Dr. Brower from Hopkins, who's one of our really national, international leading researchers and thought leaders in ARDS, talking about ARDS. Dr. Mitchell Onwechiashe from Inova, talking about fluid responsiveness. Yuna Jung from Hopkins, Dr. Yuna Jung, I should say, who's one of our cardiac surgical intensivists, talking about cardiac output monitoring. Dr. Chinadozi from Hopkins, who's another of our cardiac intensivists, talking about transesophageal echocardiogram. Dr. Menbeu talking about hepatic encephalopathy. Dr. Flick from Hopkins talking about antibiotical pharmacokinetics. Dr. Kaufman, who's one of our trauma surgeons, talking about refeeding syndrome and nutrition in the ICU. Dr. Winters is another another critical care quality researcher and thought leader, talking about ventilator-associated pneumonia. And Dr. Seth from Hopkins talking about CNS infections. And then we have the whole second half of the year that we're looking forward to filling out that schedule for also. I should mention that the format for this, we'll plan to have about 45 minutes for each of those experts to give a lecture on their topic. And then after that, we'll have another 30 minutes time for clinical case-based discussion that's led by an African faculty member, either from Ghana or Ethiopia, to translate how some of those international research findings and practices apply or don't apply in your settings at this time. Like I mentioned earlier, technology continues to evolve. Many of you will practice in multiple different environments with different levels of resource availability throughout your career, and things that were really not widely available or feasible even 5 or 10 years ago are becoming more accessible now, and I think that will continue to change over time. So even things like transesophageal echocardiogram that may not be available in your institution right now, we expect will continue to change over time. And so I think having some familiarity with those modalities and treatment approaches, diagnostic approaches can be really helpful as you're launching into your careers. I will say that our professional culture is probably a little bit different in the United States. We'll try to start all of these meetings exactly on time, on the hour at so it'll be 4 p.m. in East Africa, which I think is that 2 p.m. for you guys in Ghana, Chris?
It will be 1
the same.
It will be 1
1 p.m. in Ghana.
Yeah.
Great. So we'll try to really start on time. I think that the unintended implication, if people are not attending or if people are trickling in late, can come across as being uninterested or even disrespectful to our faculty. So I really appreciate you guys, and seeing how many of you guys were able to show up at the starting time today. We are going to continue to ask and appreciate you guys making the effort to show up at on the hour so that we can start right on time, be respectful of the time of our presenters. I understand that for many of you with variable bandwidths of internet connections, sometimes there are technological issues that you're not able to log in right on time. We understand that having your camera off is often easier for maintaining good audio connection. But we do hope that you guys will be able to participate, not just in listening, but also asking questions and engaging in discussion. We'll ask that you're able to come off of camera so that when you're speaking or asking questions, so that it's a little bit easier for our speakers to put faces with voices and to connect with you guys. And then, as I mentioned, we will try to record and archive these sessions so that you're able to access them again after the fact, but hope that that's not a replacement for real-time participation, because I think that being able to really engage in conversation and show our international panel of presenters that you are interested and engaged is going to really be helpful to maintain the strength of the series as we move forward and continue to build and expand on it. And then the one last thing that I'll mention, and you'll hear about from us again in the future, is that we'll ask you after each session to complete a very brief feedback survey, just to give us a sense of what went well, what would you suggest changing if we do this again, and is this a topic that we should repeat again for future years? Because I think really having your feedback will help to make sure that we're catering this to your learning needs, and not just repeating talks that maybe are more appropriate for other audiences, but not specifically oriented to your needs as really advanced trainees in your countries. I think that covers everything from my side. Anything else from you guys, Chris and Menbeu? Oh, and I guess the one other thing I would mention is, along with your feedback for sessions, please be in contact with Dr. Chris and Dr. Menbeu if there are topics that you would like to hear more about. We would love to get your input about how we can cater this series to meet your needs. And so if there's specific topics that you'd like to see addressed, we can look for experts to address those topics.
Thank you, Adam. So as Adam had indicated, this is not all the topics we're going to deal with. You could actually see from the schedule, there are even spaces we've left in it, and we'll continue to fill this with topics. What we're trying to do is make sure that these topics are pertinent to the training of our fellows and our topic at the level of fellows. So the focus of this is not just to give a general critical care or basic critical care training targeted at everybody. The idea is that we not only build in critical care providers who are competent, but we're building the next generation of trainers and teachers of critical care. So it's going to be in-depth, looking at what the level of critical care for each of those topics should be in a place where the standard of practice and the resources are available, whilst we show adaptations that can be implemented in our setting in cases where there are limited resources. So there is going to be a lot of physiology, there's going to be a lot of physics, there's going to be a lot of in-depth pathophysiological discussions of diseases in this series. We know that there are other trainees that may benefit from this, especially in our hospitals where critical care is provided by emergency physicians and anesthesiologists. And we are happy to open up, but with limited spacing so that we can concentrate on who our focus are. We would focus on making sure that the fellows benefit the most from this. So as Adam said, along the line, if there are topics from Ethiopia, from Ghana, from the facilitators that you think that had to be missed or should be added, we will add them as we plan the next batch of schedules. So I think, Adam, I can share the template for our lectures and quickly run through that. And for the facilitators that are here with us, you would have either received those templates, or you will receive them from Amanda to guide you in preparation of your presentations. So this is the template we'll be using. Basically, presentation should be approximately 45 minutes long, and each presentation will be followed by a 5-minute debrief and a 25-minute Q&A session with fellows. As we have indicated, we would always have tied to an international or a seasoned presenter, one of our fellows from either Ghana or Ethiopia, to give a brief context-based direction, especially in cases and discussions, what is available, what can be adapted. And this would be incorporated in this 30 minutes total after the presentation. We've said all sessions will be recorded and posted on our open source website. We have in our invitation to presenters ask for permission, and if anybody does not want that to be done, should kindly indicate to us in the response. So this is what the template looks like. So you would notice that we've left a space for presenters who are not from any of our 3 institutions to insert their institutional logo if they so wish to. And then any disclosures or conflict of interest on slides, if there's none, please just state that you have no conflict of interest. We will be happy if clear learning objectives are spelled out at the beginning of every presentation, so that we're able to use that to also assess what our fellows are supposed to take home from their presentations. We, as mentioned earlier on, aim to periodically have an assessment of our fellows based on this lecture series. Then, of course, your main slides in any format that you want. And then, so this particular slides gives opportunity for our fellows to reach out for any clarifications Menbeu and I are going to coordinate that just to ensure that presenters do not also feel unduly harassed. So if there are any clarifications, part of what we want to do is build also a network between our fellows in Africa and nurture them while we network them to the global network of practice that we find ourselves in. But we would ensure that we do not step out of the boundaries. We ask that, if possible, insert about 3 to 5 knowledge check questions to your presentation, and the fellows would answer these questions during the presentation. It can be at the end, it can be as transition slides along the line in your presentation. So that is what, and then of course, any references or citation acknowledgements of materials used following best practices, global best practices. So that is the our template for the presentations. As I said, we will share that with all the presenters. And then if there are any clarifications that you need, feel free to reach out to Amanda to support you in that. Yeah, Adam, over to you.
Thanks, Chris. I think we're just coming up to just at the hour now. I think that we could probably wrap up if you and Dr. Menbeu have any final comments before we close, and then we will get started next week with our first lecture.
Thank you, Adam. None from my side. Thank you, everyone.
Yeah, and from my side, I want to say a big thank you to all of you who have joined and to all the facilitators who have agreed to support this program. We look forward to meeting all of you in the next meetings. We would, again, ask for permission to send communications to you, including reminders of a presentation. And the link that was used for this meeting is a repetitive link for every week's meeting series. As long as you have registered for the first time, you have the link to join every meeting every Wednesday. Thank you all for joining us.
Thank you, Dr. Menbeu, Dr. Chris. Amanda, any last minute comments from your end?
No, nothing from me. Thank you all very much.
Well, great. Well, again, thank you all for joining today. It's great to see some familiar names and to look forward to meeting the rest of you as we go through the year. Yeah, I guess we'll look forward to seeing you guys all next week.